Well, hello. This is Lori with Med Made EZ, and I thought I would go ahead and kind of read with you guys. I'm working on a chapter with someone that I tutor, and I thought I'd just go ahead and read since I'm reading it. It's about dyslipidemia. So I think that this is a great chapter. I really like this book. The name of the book is Pharmacotherapy Principles and Practice, and the chapter is the dyslipidemia. So I've found a lot of great tips and tidbits from this. I think this is a great one to begin with. So we'll go ahead and I'll put what I'll probably do on my iPad because I'm reading off of my Mac. Is I will write key points if I find any that I think are really important. Yeah, so let's just go ahead and jump on into it, and I will read, and you guys can follow along, and hopefully you get something from this. So let's go ahead and jump into, and sometimes I speed read, so that's something that you may notice that I do. I may go past certain things that I do not feel are super important for what we're learning. So lowering cholesterol reduces atherosclerotic progression and mortality from CHD and stroke. Development of heart disease is a lifelong process, except in rare cases of severely elevated serum cholesterol levels. Years of poor dietary habits, sedentary lifestyle, and life habit risk factors, smoking, obesity, overweight, contribute to the development of atherosclerosis. So the other thing that I'm going to do, because I'm kind of filling out a little sheet here to go over, the first thing that I'm really going to be looking for in this chapter is I'm going to be looking for lifestyle management is the foundation for dyslipidemia, what should be included as part of the comprehensive interventions. So that's what we're going to look for, is we're going to look for interventions. I've been out weeding today in the with my plants and stuff like that, so I apologize if I've got weed dirt hands today. Sometimes even when you wash your hands, sometimes it will take problems still. So all right, so intervention. So let's talk about the pathophysiology of dyslipidemia. Cholesterol and lipoprotein metabolism. Cholesterol, an essential substance manufactured by most cells in the body, is used to maintain cell wall integrity and for biosynthesis of bile acid and steroid hormones. Cholesterol, triglycerides, and phospholipids circulate in the blood as lipoproteins. And the major lipoproteins are cyclomicrons, let me see where, very low density lipoproteins, intermediate density lipoproteins, and high density lipoproteins. Each lipoprotein has various proteins called APOS embedded on the surface. So I'm going to go past this because this is not really, as I'm reading here, this is not exactly what I'm looking for this particular student. Let's see here. So one thing that I think, let's go ahead and just kind of get rid of that here. One thing that I think would be important is LDL cholesterol equals the total cholesterol minus HDL cholesterol plus triglycerides when lipids are expressed in units of milligram per deciliter. Or LDL cholesterol equals total cholesterol minus HDL cholesterol plus triglycerides. I think I might go past this. Just looking here. Just looking at some different things that I think are important. So I do have a chart here that goes over secondary conditions and drugs that cause dyslipidemia. So anorexia can cause increased LDL. Chronic kidney disease can cause increased LDL. In addition to that, increased triglycerides. Oh, here. And for the sake of time, I'll just abbreviate it like that. Diabetes we know triglycerides are going to be on this definitely. Often people who have thyroid disease, diabetes, alcoholism will have increased triglycerides, but we'll definitely. So we see increased triglycerides and decreased HDL, and that is very true. Hemodialysis patients, we see increased triglycerides, hypothyroidism. Once again, we're going to see increased triglycerides. I'm not even looking at it yet, but in addition to the triglycerides, we're also going to see increased LDL. So, and this is on a lipid panel. What we would typically see, sorry, my handwriting's being a little bit messy here. This is what we would see in different conditions on a lipid panel. Nephrotic syndrome. We're going to see all three. So whenever we see, so we're going to have triglycerides, increased LDL, and then we're going to have decreased HDL. Now, if you remember what HDL is, I always think of like happy, healthy cholesterol. I always think of it like the cholesterol that drives the bad stuff out. L is not the good. We don't want this to be higher because we can think of this as the bad type of cholesterol, or lousy, L for lousy. And then triglycerides are the fats in your blood. Obesity. So obesity is going to be pretty similar to diabetes. We're going to see increased triglycerides. Oh, actually, I put these two together. We see metabolic syndrome often in patients who are obese. So we're going to see triglycerides are increased and HDL is decreased. Okay. And then let's look at any kind of, let's talk about medicines. So anabolic steroids. We are typically going to see increased HDL, increased LDL and decreased HDL. And then beta blockers. With this, we can see increased triglycerides, and we'll see decreased HDL. Let me look at my comments just real quick here. Hello, 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 everyone. Do you know? I don't know what that means, but hello, everyone. Welcome, and hopefully you can see. Sorry if it's kind of off to the side here, but just kind of going over some different reasons why we'll see lipid panels abnormal. Estrogen. Typically with estrogen, we're going to see increased triglycerides and thiazide diuretics. I'm trying to put some of the more common ones. Thiazide diuretics, we're going to often see increased LDL, increased triglycerides. Close period. So these are some different things that you'll see in abnormal. And sorry, my handwriting, I was kind of writing fast, so that's why it's a little bit messy there. But some on the lipid panel, what we're typically going to see with different conditions like anorexia, increased LDL, CKD, increased LDL and increased triglycerides, diabetes, increased triglycerides and decreased HDL. And you'll often see this together, increased triglycerides and decreased HDL. Hypothyroidism, increased triglycerides and increased LDL. Nephrotic syndrome, increased triglycerides and increased LDL, decreased HDL. Once again, happy, healthy cholesterol, lousy cholesterol on that one. Obesity, increased triglycerides, decreased HDL. Anabolic steroids, increased LDL, decreased HDL. Beta blockers, increased triglycerides and decreased HDL. Estrogen, increased triglycerides, and thiazide diuretics, increased LDL and increased triglycerides. So I'm trying to see if there's what else I can kind of give you guys. So that's a great little tidbit there. Hello everybody tuning in. So let's talk about some of those lifestyle changes that are really important in dyslipidemia. So let's just put lifestyle. So some of the changes that you want, obviously, is you want dietary cholesterol to be under 200. And then milligrams per day. So there's that. And then you want to increase your increase your soluble fiber. It's very important. And we want that 10 to 25 grams a day. And then we want to also increase physical activity, which also will increase your HDL. Not always, but that's the happy cholesterol. So we want this increased if we can get it, because it helps to drive out the bad stuff. Now, the general recommendation is for physical activity is 150 minutes per week or greater of moderate intensity activity. So, or let's say you do some crazy activity. Let's say you're doing pickleball or something like that, which can be, that's a pretty popular thing right now. 75 minutes a week of vigorous. So that's the difference there. Let's highlight that. So these are just some things that you can do to be able to help to keep your cholesterol in check. So soluble fiber, let's talk about that just real quick here. I'm going to go ahead and look something up. So this type of fiber dissolves in water and forms kind of a gel-like material, and it can help to lower your blood cholesterol and also glucose levels. It's found in things like oats, peas, beans, apples, citrus fruit, carrots, barley, and psyllium. So just a tidbit on that. And then as far as total calories, you want to adjust the caloric intake to maintain the body weight and prevent weight gain. So everyone's a little bit different depending on their activity. So everyone is obviously going to have a different amount as far as that. And then let's see here. Let's just take a look here. Trying to see what other kinds of things I can tell you, but I think from these charts in this book that are really good. Obviously, one of the biggest first things that we want to do is that lifestyle, healthy lifestyle preventions. And if there is any kind of high risk for coronary artery disease and strokes, myocardial infarction, things like that, obviously we're going to want to be we're going to have a lower threshold for when we start medicine. Let's see here. I'm just looking through here, trying to see if there's anything. Some different. So let's go over statins, okay? And let's talk about the LDL lowering medications. And let's talk about their intensity. And then the interesting thing about statins is just because one doesn't work for you, or you have an issue, let's say you have muscle aches or myalgias with one of them, you can always switch to another one in the class and not have the same issue. So we do, we have the high intensity, which is going to be a atorvastatin. And then we have the rosuvastatin. Okay, so that's high intensity. So someone that has higher risk would be important. And then to be using that. And then moderate intensity statins include things like atorvastatin. And then rosuvastatin, it's based on the dose. It's atorvastatin, and actually, I'm sorry, I apologize. The atorvastatin here would be 40 to 80 milligrams, and the rosuvastatin here would be 20 to 40 milligrams. And then down here for the moderate intensity, it would be 10, looks like it's got 10 to 20 milligrams. And rosuvastatin, here for moderate intensity, would be 5 to 10 milligrams. And then simvastatin, it's a very common one, 20 to 40. This is per day. And then pravastatin, it's one of the ones that doesn't have as many side effects as the others. Pravastatin, 40 to 80 milligrams. Lovastatin, fluvastatin, I'm not going to write those down, but those are some of the other moderate intensities. And then we get down to low intensity. So it's not going to probably lower the LDL as much as the other ones. So with that, we have simvastatin, sorry, my handwriting, simvastatin 10 milligrams. So you see up here moderate, we have, and let me make sure here, we have the 20 to 40, and down here we have 10 milligrams. And then the pravastatin, which is the one that I was saying that doesn't have as many side effects a lot of times, 10 to 20 milligrams. And then the lovastatin, we have 20 milligrams. So where's the, on the moderate for lovastatin, it's 40 milligrams. So these are just some, the strength or their intensity, I guess you could say. So hopefully that's helpful. And then, and this is all coming from the Pharmacotherapy Principles and Practice book. It's a great book. And then let's go ahead and take a look here. We'll go down to the next one, actually. I'll leave that up for just a minute. And then, so let's talk a little bit about recommendations for treatment. So the first thing, according to this book, is step 1, you want to screen and classify. And in this, here the key concept is that the American Heart Association recommends that either a fasting or non-fasting lipid panel can be performed. They specifically recommend a fasting panel on a different day if a patient has ingested high-fat meal, because that obviously can increase, that can skew the labs, specifically the triglycerides, in the preceding 8 hours. So we want to make sure that they're fasting for 8 to 12 hours. Usually can have, obviously, water. We want them to drink water. And then the other thing is, or if tested and the LDL cholesterol is less than 70, as the Friedewald calculated LDL cholesterol is less reliable. And then it says that it's recommended that all adults older than 20 years old are screened every 5 years. So 20 years plus, screen Q 5 years, every 5 years, to obtain a lipid panel. Okay. And then children between 2 to 20 years old should be screened for high cholesterol if their parents have premature CHD, or if one of their parents have total cholesterol greater than 240. So that's kind of an interesting one. And then put step 1 here. Step 2, you're going to rule out secondary causes of dyslipidemia. Certain secondary causes like drugs and diseases can cause abnormalities in serum lipids and should be evaluated. Every effort should be made to correct or control underlying disease such as hypothyroidism, diabetes. Concurrent medications known to induce lipid abnormalities should be evaluated for discontinuation if alternative medications can be used prior to instituting long-term lipid modifying therapies. So in here, we would say, like an example of diabetes, thyroid, specifically hypothyroidism. If we have maybe something like, let's say like a thiazide diuretic like hydrochlorothiazide, steroids can do it, estrogen. So those are just some ideas, and we want to maybe adjust as needed and also treat these things before maybe even adding, depending on where we're at. And then step 3, we want to identify patients with really high-risk conditions. So ID patients with high-risk conditions. And we're talking really very high, so I should probably put very on there. Very high risk conditions. These are the people that we're going to really be looking at and saying, you know what, they're probably going to end up having the high risk. They are likely to have an MI or myocardial infarction, heart attack, a stroke. These are people that this is what we're really looking at here, and a lot of other issues. So, and also to consider here as well is if there's any kind of evidence of atherosclerotic mediated end organ damage, that's actually considered very high risk, or what we call extreme high risk. So it's important to keep that into consideration. So as far as risk factors for atherosclerotic cardiovascular disease, the things that we really want to look for, or we want to pay attention to, the age. So males equal to or greater than 45 years old, and then females equal to or greater than 55 years old. So there's one major risk for atherosclerotic cardiovascular disease. And then family history, that's a big one as well, especially if it's premature. Cardiovascular disease. So if we have, for instance, for males, if we have a first-degree relative under 55 years old that had some kind of cardiovascular event, and then females under 60, first degree, under 65 years old. Okay. So these are just risk for the cardiovascular disease, atherosclerotic cardiovascular disease. Another one is if the blood pressure, if systolic blood pressure is greater than or equal to 140, or the diastolic blood pressure is equal to or greater than 90. And then another risk factor is if the HDL is low, the HDL cholesterol. So in males, if it's under 40, and under 50 in females. And then smoking. Smoking, we know, does nothing good. And then if they're current, we need to get them to quit, because these are high risk. These are all high risk for a atherosclerotic cardiovascular disease. And so we need to really make sure that we are making sure that we're screening earlier, making sure that we're screening not only for family history, but any kind of lifestyle factors as well. But big one here is family history. If there's anybody first degree and males under 55 years old that's had any kind of events, and then also the age is an important factor. And if we need to look at their blood pressure, I wouldn't just go off of one reading. I would look at the patterns there, and then their HDL and smoking as well. So, and just to give you a heads up, that CHD, this one particularly right there, is defined as myocardial infarction, so heart attack, coronary death, or any kind of revascularization. So if they had a CABG or... So these are all what that means, okay? And then kind of going down here, after we've gone from step 3, let me see here real quick, because I think I skipped over writing down step 4. Where did it go? I'm not seeing step 4, but let me make, oh, there we go. So that's step 4. I was gonna say, that's what I thought it was, but then I didn't see it. So this is, we need to ID high risk. But wait, hold on just a second. Let me go back up here and make sure I got this. So on 3, we're identifying patients with very high risk conditions. And then step 4 is very similar, but it says ID patients with high risk conditions. So this is very high risk. So let's say if someone already had a stroke or a heart attack, and then this is kind of on that same realm, but just a bump down. These are people that are at risk for these kinds of things here. So we're doing very high here, very high risk, and then this one we're doing high risk. So let's highlight that. So that's, we're identifying these on both of those. So step 3 is kind of the bigger one if they've already had some kind of event that's happened. And then step 4 is identifying things that are kind of risk factors for them to end up having something like that, or any of these, like a coronary death or revascularization. So we're on step 5. So let's jump down here. Hopefully I'm not running out of, so hopefully you guys can see that. So step 5, and so what we're doing in this is we are identifying patients without established atherosclerotic cardiovascular disease. Risk factors. And then we want to get a quantitative risk score. Apologize, that looks terrible, so I'm gonna rewrite it. Risk score, and it should be obtained for adults 20 years old and older. Okay. And then let's see what else we've got here. So I think that's pretty much, there are a lot of things that fall under this. So if they had things that kind of the risk enhancing factors for clinician-patient risk discussion include things like family history, premature atherosclerotic cardiovascular disease, primary hypercholesteremia, metabolic syndrome, chronic kidney disease, chronic inflammatory conditions like RA, psoriasis, HIV, AIDS, history of premature menopause, history of pregnancy-associated conditions that increase later atherosclerotic cardiovascular disease, such as preeclampsia, high-risk race and ethnicities, lipid biomarkers, and then so then step 6 is going to be treatment of elevated triglycerides. And so just a key concept here, patients with severely elevated serum triglycerides exceeding 500 are increased risk for things like pancreatitis, especially when levels are elevated above 1,000. Reducing triglycerides in these individuals become the primary target for intervention. Reduction of fats and carbohydrates, especially obviously processed carbs, and abstaining from alcohol. It's an obvious one. And you should consider all of these things for secondary causes of that, definitely. These things should be assessed. So you should really look into their diet, What are they eating? Are they eating a lot of high fatty foods? Are they eating a pack of bacon every morning? Are they eating like ho-hos and donuts and all kinds of things like that? How much alcohol they're drinking? And when you're asking somebody about how much alcohol that they're drinking, you need to be very specific, because a lot of patients will say things like, oh, I don't drink that much. The thing is, you need a quantity. This is not something just to go off of subjectively. You need to really try to get it kind of narrowed down to a number. So whether that's how many do you have per day, how many do you have per week, you really need to know that. And patients will sometimes tell you a lot less, especially if they're kind of in denial of their problem. A lot of times they will tell you a lot less than what their number actually is. So once the triglycerides are less than 500 and the risk of pancreatitis is reduced, the primary focus intervention should be, once again, on non-HDL and LDL cholesterol, niacin fibrates, and long-chain omega-3 fatty acids are the most effective agents in fasting to triglycerides, concentration greater than 1,000. So really what it's saying here is that you need to kind of look for secondary, this is the way I'm going to write secondary causes, okay? And then once you get it under 1,000, then you're going to go ahead and do your treatment. And so really what we want to do, the other thing too we want to really recommend is weight loss. We have a lot of drugs out there that are available now, so that's something that definitely should be instituted or recommended. And then our goal that we really want here is that we want our triglycerides less than 150. All right, so let me go ahead, and I need to put in another paper here. I love my iPad. My iPad has been an absolute lifesaver, it feels like. And it's kind of nice to make notes and things like that. All right, so let's see if we've got any more steps here. All right, so that's pretty much everything with the steps. Just to kind of go over them just real briefly again here, where am I? Step 1 for treatment, you want to screen and you want to classify the patient. Make sure they're fasting for at least 8 to 12 hours. They can drink water, that's okay. Everybody 20 years and older should be screening every 5 years. They should get a lipid panel every 5 years. I will tell you that fasting can make a huge difference. Step 2, you want to rule out any kind of secondary causes, things like diabetes, hypothyroidism, also medications as well, like thiazide diuretics, steroids, and estrogen. You may have to either change something here with the medicines and also treat here to make sure that these things aren't contributing to that, because a lot of times they will. Beta blockers is another one on medications as well. Step 3, identify patients with very high risk. And so I always think this is higher up on the steps, because we want to look at very high risk as people that they've already had some kind of coronary event, whether it's a heart attack or strokes, just a very high risk. And then step 4, then we're looking at the high risk. That's the difference between here's very high and this is high risk. So that can get a little bit confusing sometimes, but this is kind of the different things here that increase the risk, like a family history of some kind of cardiovascular heart disease or coronary heart disease, like a family member who had a heart attack or coronary death or any kind of vascularization. Age is a risk factor, hypertension at these levels here as far as the numbers, low HDL, and smoking as well. And then step 5, we want to identify patients without established atherosclerotic cardiovascular disease risk factors, but we want to get a quantitative risk score to see if there's maybe some that we're missing there. And then step 6, we want to make sure to treat the triglycerides, especially if they're over 500. That is increased risk for pancreatitis. A lot of times we may need to look at secondary causes first to see if it's things like, are they eating a lot of fats? Did they fast before they came in? Are they eating a lot of? Are they drinking a lot of pop? Are they drinking or eating a lot of processed carbs? Then once we get things under control and we're doing labs, if it's still elevated, we can consider treating with medications. Weight loss is also something that we need to recommend in these patients. And also our goal is going to be to get those triglycerides under 150. So I'm going to go ahead and stop here for now, but thank you guys for hanging around and listening to this dyslipidemia chat here, and my computer's getting ready to die. So you guys have a good day, and hopefully this is helpful. And if there's anything else that I can answer for you guys, please let me know.